My name is Christine Coe, and I'm an associate professor of dermatology and pathology at Yale University. And today I have the pleasure of interviewing Timothy McCalmont, who is a professor of pathology and dermatology at University of California in San Francisco, as well as co-director of the Dermatopathology service there. So thank you for allowing me to interview you today.
Thanks for talking to me.
So you are the 2015 Elson B. Helwig Memorial Lecturer for the American Society of Dermatopathology, and I thought I might just ask you what, for those of us who are able or maybe not able to listen to the lecture itself at the annual meeting, what do you think are some major takeaway points that you're going to go over?
So one of the things that I care very deeply about is diagnostic precision. I think that the looking at slides that we do and that we love, oftentimes we're actually not very good at our jobs. We think we're good at our jobs, but we're not actually good at our jobs. And the thing that shows us that is when we share cases with colleagues, they often have extremely different perceptions of the same information. And so we're all aware of that phenomenon. So we're going to talk about diagnostic precision and ways to look at things, and then also diagnostic concordance, which is really sort of the close relative of diagnostic precision, because if your data extraction from the slides or information is not precise, then of course you're going to have diagnostic variability, and you're going to notice that lack of concordance between different groups, different individuals, whatever.
Mm-hmm. And in your experience, do you think that there are ways to increase precision and concordance between sort of intra-observer as well as inter-observer?
I'm better at answering that question on the personal level, intra-observer, and I call with the fellows, I joke about it being like a robot, and so I actually, at work, and when I'm doing my work, I actually try to be completely robotic. And what I mean by that isn't that I would walk stiffly or make mechanical sounds. What I mean by that is that I want to react to a particular circumstance in exactly the same way over and over and over again. I want to be like a robot. I don't want to see a particular situation and react one way one day and react a different way on a different day. And so I've worked, I have a personality type that's kind of prone to this type of repetitive thing, so I think that's a lucky break from my parents, that I have that. But that's really what I try to do to work on in my personal reliability, repetitive qualities. And I would encourage others really to do that same kind of thing, always react the same way. In terms of the person-to-person variability, that's much harder. My personal approach in improving that is really speaking, teaching, talking, collaborating. But I would say that we're a bit stuck. I think as a society and as a practice, probably all physicians are, so I'm not speaking badly of dermatopathology, but I think that it is a problem that we do seem to have some diagnostic volatility, mm-hmm. that is in a larger sense, is a disservice to patients.
Mm-hmm. Well, it's interesting you say that about being a robot, because I've recently read a book called The Power of Habit. I don't know if you're familiar with that book, but it kind of goes over that, how we don't realize, but a lot of what comes automatically to us is actually just habit. What we do when we first wake up in the morning, sort of the order of the sequence of the things we do. Also driving, I found this especially was true for me. Driving, we tend to take the same route, say, to work every day, and we essentially do that often on autopilot, essentially, like I guess a robot would. We're not thinking, and so if something causes us to need to deviate from that, it can actually be very difficult to take a different route for whatever reason and sort of end up at the same place that you were aiming to get to. But are there ways that you sort of test yourself to see how close to being a robot you are, or methods that you use to try to train yourself to do that?
Well, there are a couple. I'm not sure I can completely describe them, but I'll try. One is that one of the problems of being a human being is being emotional, and you can have ups and downs, and you can have ups and downs in the workplace. You can have ups and downs about cases. You can be disappointed in yourself. All of those things are non-robotic, and I try to really eliminate those from my personal work. Barack Obama has said that about politics, that it's never as bad as you think it is, and it's never as good as you think it is. And I think he's really, irrespective of what you think about him as a politician and as a leader, I think he's got a very even keel. And so I tried to basically be similar to that, not get too high, not get too low, not be too jokey, not be too disappointed when things go wrong. So just try to keep myself in an emotional state where I can do the same kind of task over and over again. I am, again, a credit to my parents. I have a kind of a knack, I call it situational memory, and what I mean by situational memory is I'm pretty good at remembering myself in the same situation before. And so I see a weird case, I spend a lot of time thinking about it, I get to a point, maybe there's external information that gives me the answer, and I'm like, oh yeah, I got that. And so then when I see the same kind of situation, I'm like, oh, it's that situation. And I do it less now, which I think comes with experience. I used to do a lot of what I call comparative dermatopathology. So I'd see something and I think, I've been here before, and I'd actually go to the file, pull out similar cases, look at them, and I would say, yeah, this is a consistent thing. And then that builds that situational memory. And so then over time, you can say, yeah, I'm there again. This is how I deal with that situation. And it has the tendency over time to make you more robotic.
That's interesting. That's wise. And I think there's nothing, for me at least, there's nothing that kind of compares to seeing the same entity side by side, kind of putting it on the scope and then putting something else that you think looks like it next to it and comparing it like that. So I think that's interesting.
I think the comparative dermpath thing is, especially for people earlier in their career, but probably at any time, is a good thing. It's also fascinating that once you've done comparative dermatopathology, to take it to a colleague and see if they perceive the thing as the same way. I do a little bit of this with Phil LeBois. He showed me 2 cases and he said, do you think this is the same thing? And I'm like, yeah, I definitely think it's the same thing. And it's a very unusual pattern. I won't say anything more about it. But so it's like a new find, and something that is, and so in order to build that kind of finding cases, whether it's like a part of a case or a completely new entity, you have to remember the first one,
right,
and then you have to add in, and then you have to go back and you have to decide, is this the same thing or is this a different thing? We do a lot of, in our database, we do a lot of secondary coding, and which is invisible to the world except for us, but it's a way where you can add tags to cases basically and say, this is, and you can write it in your own language, but this is what I think of this, and then at another point in time you can go back and say, I want to find all of the whatever, and then look them up.
Well, I've always enjoyed reading your editorials in the Journal of Cutaneous Pathology, and I thought I might just ask you some of your opinions on various things.
Well, my opinions are in the editorials, so, and I've expressed a lot of them. And so usually with the editorials, there's been something that's come up in a case. Sometimes it's a big thing, sometimes it's a small thing. I usually try to tie it to the journal. And so then I'll just something that doesn't sit right or something that doesn't completely make sense, and then I'll try to turn it into a little commentary, and hopefully other people that are getting stuck in the same little spots or notice the same little things that don't make sense when they read the commentaries, that has some appeal to them, and hopefully it helps them in terms of their day-to-day practice. Maybe it gives them a new insight that helps them better do their day-to-day job.
Well, and my last question will just be, where do you think dermatopathology will be in the next, say, 5 or 10 years?
So one of the things I'm going to talk about in my lecture tomorrow, the Helwig Lecture, is the accelerated pace of change, and which is really, really quite phenomenal. Ray Kurzweil is a futurist, and he's the director of future thought for Google, which is obviously a gigantic operation that is trying to figure out how to position themselves for the future. And Mr. Kurzweil, as a futurist, has predicted correctly, if you go back and forth, about 85% of the time, which is a remarkably good ability to predict by a human standard, because I think a lot of us would say our predictions are much lower than that. But I think what is his special capacity for prediction is the fact that a lot of change is logarithmic. And so, for example, if you look at the Human Genome Project, when it was put forth in 1990, it was a 15-year term, and after 7 years, they had 1% done. And the naysayers said, there's no way this is not going to be done. There's just not time. And so Ray Kurzweil said, they're going to be done early. And it turned out that he was right because of logarithmic progression, and so they ended up getting done, I think, in 13, 14 years, but the well within the time frame. So some of the technologies that were used to complete the project hadn't even been invented when the project started. So you can look at that and say that is fanciful thinking, but I think it's forward thinking, and it reflects the kind of logarithmic change that occurs. So with logarithmic change in medicine, I think that dermatopathology in 5 years will be recognizable. I think in 10 years it will be barely recognizable, and I think in 15 years it'll just be a completely different paradigm. One thing that has to be sorted out is as molecular approaches get more and more inexpensive, is what's the value of slides. And I think there will be some permanent value because it's just it's cost effective, it's slick, it lets you check margins, there's all kinds of things so I think there's part of our day job that is going to be similar and recognizable, but I think there's other components that, because of logarithmic change and because of the rapid progression of molecular medicine, is just going to be so astoundingly different that's the part I mean that we won't be recognizing it. So love your melanomas now, because the paradigm for diagnosing them a few years from now, I think, will be completely different.
Well, thank you very much for spending the time today with me and with our viewers. I really appreciate all the insights.
I enjoyed it.